right, it's 12:02. Let's go ahead and get started. Hello and welcome everyone. Thank you for popping in today. We have a great panel. We have faculty member Meredith Sjogren and staff David Terry and Abby Roach-Moore. They all work within the Addiction Technology Transfer Center, also known as the ATTC, right in the College of Nursing. In case you didn't know, the ATTC is housed on the second floor of the Northern Plains building, along with the Mental Health Addiction Technology Transfer Center. Both centers are funded by SAMHSA, and both have a plethora of resources available. I hope you hop on their website and check out all of their offerings. Today, though, the staff are going to talk about a toolkit for depression, alcohol, and farm stress. Please mute your mics so the presenters have our full attention. Also, if you're experiencing internet brownouts, please turn off your video. That seems to help reduce those internet interferences. We'll hold questions until the end, but you can ask questions in the chat box during the session, or you can wait till the end and ask in person. So thank you, Meredith, Abby, and David for being here today, and I'll let you get rolling.
Great. Thanks so much, Sherry, and thanks for the introduction. So as Sherry mentioned, my name is David Terry. I'm a program manager for the Mountain Plains Mental Health Technology Transfer Center, and I am colleagues with Abby and Meredith. So thanks so much for joining us today. And because we are funded by SAMHSA to provide today's training, I get to read these wonderful disclaimers. Today's presentation is provided free of charge by the Mountain Plains Mental Health Technology Transfer Center and the Mountain Plains Addiction Technology Transfer Center. Today's presentation is available in the public domain and should not be distributed for a fee without the express written permission of the Mountain Plains MHTTC or ATTC. The views and opinions expressed during today's presentation are those of our presenters and do not reflect the official position of the Department of Health and Human Services or SAMHSA, and no official support or endorsement of DHHS or SAMHSA is intended or should be inferred. And if you have any questions about that disclaimer, please feel free to contact us. And so a little bit more information about the Mountain Plains Mental Health and Addiction Technology Transfer Centers. So the Mountain Plains Mental Health and Addiction Technology Transfer Centers are one of 12 respective centers that make up the larger MHTTC and ATTC networks. The MHTTC and ATTC networks are funded by SAMHSA to aid in the dissemination and implementation of evidence-based practices in the areas of prevention, treatment, and recovery support for substance use disorders and mental illness. The Mountain Plains MHTTC and ATTC serve the states of Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming, and have a particular focus on supporting providers working to meet the needs of individuals living in rural communities. And as I've noted, we are funded by SAMHSA to provide today's training. The only thing that SAMHSA asks in return for us providing all of these free trainings and resources is that you take a very brief moment to complete a survey about today's training. We do use this information to improve our future trainings, and I promise it is very brief. So we'll be dropping this link in the chat box later in today's session. And the MHTTC and ATTC networks are committed to aligning our training and actions to support affirming, respectful, and recovery-oriented language in all of our training and activities. We recognize the important role that person-first, culturally responsive, inclusive language plays in supporting the mental health and healing of all individuals. And we encourage you to visit our program websites to learn more about these initiatives. So thanks for sitting through our little housekeeping notes, and thank you so much for joining us today. We're really excited to discuss this toolkit that Meredith, Abby, and I, and some other folks affiliated with our programs authored that examines co-occurring substance use and mental health disorders in rural and farming communities. And a little background on why we chose to focus on this topic and why we were tasked with focusing on this topic. Both of our programs conduct regional needs assessments to determine the challenges faced by providers across Region 8, and also to prioritize training to help support providers in our region. In both of our needs assessments, Co-occurring substance use and mental health disorder treatment was one of the top 5 training needs for both of our programs across our region. So there's very heavy interest in this topic, and it's a very well identified and well-defined need. In addition to this, our MHTTC and ATTC have identified that farm stress is an increasing challenge for individuals in our region and quite honestly across our nation. So it's something that we've provided several trainings on and have kind of made a particular focus of our programs over the past couple of years. And so with that context in mind, we really set out to help provide a framework for providers serving persons in rural communities. And we know that farm stress is a far-reaching issue that really, it impacts families, businesses, entire communities. It impacts healthcare professionals and really requires a multidisciplinary approach to properly respond to it. And we really recognize that, when working in rural communities, providers face some unique challenges in identifying and treating co-occurring disorders. So this is our toolkit. I think it looks really, really pretty and really great. We're very proud of it. We spent a lot of time trying to find some images that we felt really represented rural communities. And if you would like, we'll note this at the end of the session, but if you would like a physical copy of this, I know Sherry has been taking attendance for today's session, and you can work with her to request a physical copy for yourself. So to contextualize farm stress, we really wanted to give a bit of a background and foundation to the rural landscape. We wanted to make sure that people accessing this toolkit really understand what the rural landscape is. And we know that for a lot of people that grew up in rural, this probably isn't new information, but then for people that are totally new to rural, this may be a really challenging and also kind of intimidating topic. And we've heard that for some people, the idea of rural culture is a totally foreign concept and is something that is really challenging as they try and approach treatment or even interacting with folks from rural communities. So we wanted to give some definitions, but the definitions of rural really aren't concrete or don't exist. There are more than a dozen definitions of rural. They are so difficult to pin down and have consensus because there are constantly changing community demographics. Urban sprawl impacts definitions of rural. Rural communities are diverse. They have diverse geographies. They have diverse peoples. But there are some commonalities to rural. Those are low population density. Generally, they're sparse. They are usually isolated or at a large distance from major urban centers. So those are some commonalities. And here is a picture of Merity's family farm that's up in northwestern Minnesota. So we do have some real ties to our definitions and our experiences with rural here on our team. So while we don't have one shared or common or easily agreed upon definition for rural, we do have some things that are kind of threads throughout rural culture. But what we really like to say is if you've seen one rural town, you've seen one rural town. No two communities are the same. Rural communities are not homogeneous. There are some cultural similarities, usually independence and self-reliance, especially with farming families or farm communities. Those tend to be some kind of commonalities, but it's not a given. Some things that are really important to consider when discussing rural healthcare and especially treatment for co-occurring disorders is that rural communities can tend to be a bit of a fishbowl or have this goldfish effect where because they have such low population density, they are isolated, there is a real lack of privacy. We have heard from several of our trainers that one of the biggest barriers that people identify is they don't want, if they go to the clinic to get treatment, they don't want everyone in the community to see their truck at the clinic. Everyone knows their truck, they see it parked there, once or twice a week. And then some of those rumors or just that small town culture starts to kind of get going. So there can be some real barriers. I know Merity and Abby are going to talk a little bit more about the barriers to accessing healthcare in rural communities. Another common issue that can come up when trying to provide treatment in rural communities is issues related to dual relationships with providers and the people that they are working to serve, because providers are typically very ingrained in the communities that they work in. Dual relationships can be common, and it can create very muddy boundaries and can create kind of these blurred and unavoidable dual relationships. So it's something to be aware of and something to address as you start looking at this. So as I mentioned, rural communities are often served by a limited number of providers. This is probably not news to anyone, but the majority of rural areas are designated as primary care provider shortage areas and/or mental health provider shortage areas. And as you can see, our Region 8 states are very under-resourced in terms of primary care. And this becomes even worse when you consider how under-resourced they are related to mental health care. I would encourage all of you, if you're interested in learning more about how these definitions are developed and how these provider shortage areas are identified, to visit the RHI Hub. It's located here at the University of North Dakota, and they have a lot of resources for understanding provider shortage areas. So why did we focus on farmers and farming in rural communities for this product related to co-occurring disorders? As I mentioned, farming is a very high stress profession, and it is very closely tied to rural communities and rural families. So I know Meredith is going to get into the farm stress portion of it, but we wanted to give some context to farming because much like rural, there is no one kind of easily agreed upon definition for farms or farming or farmers. The USDA has very concrete definitions. So a farm is any place where more than $1,000 of agricultural products are sold or produced. A farm producer is someone who is involved in decision-making for a farm. And a farmer is a more general term that is meant to be collective and encompassing, but it really doesn't get down to the varied professions, the varied culture, the varied lifestyles that exist for ranchers, apiarists, row crop farmers. I mean, there's just this wide gamut. The nice thing about these broad definitions is it helps us, capture and identify all the people that are involved in farm production, but these definitions by no means account for all the variability that exists in lifestyle. And, good context or good example of this, I grew up in Eastern Montana, and that's where a lot of ranching occurs, and cattle ranching in particular. Cattle ranching has very different stressors than sugar beet farming in the Red River Valley. So it's a very wide and complex topic. But there are a few things that we do know about the context and composition of farms in the US. By and large, farms are predominantly family owned. They are usually identified as small farms or small businesses. They are also usually very high-risk businesses. So between 62 and 81% of all farms have high-risk operating profit margins. That's not the only stress they face, but it is a very large and real stress. They are increasingly owned and operated by women, and they're usually operated as a secondary business and are not the only or primary source of income for individuals that are engaged in farming. And with that, I'm going to turn things over to Meredith to start addressing some of the farm stress pieces.
If you'd like to go to the next slide then, David. There we go. Okay, so David's done a really good job of kind of giving you an overview of some of the information you will find in the toolkit. And this next little section, I think really keys in on our college and all of us having some of that medical background, social service background, to try to give you a little overview of that kind of didactic information you'll also find in the kit. So we do go into some detail about stressors, and in just the pure definition, a stressor is a chemical or biological agent, environmental condition, stimulus, or event that triggers stress in an organism, and that's us, people. If we look at farm stress in particular, it is similar to that definition, but also very different. So this is the stress that comes from the unique type of agricultural work that farmers and their families do. There are many resources that interchange farm stress with financial concerns or financial stress, and that is absolutely true. However, it's not the only contributing factor. Next slide. So if we try to compare what typical stressors would be, to then adding in the extraordinary stressors that farmers and farm families experience, we kind of broke them down for you. So there's always the constant responsibilities. And I think many of you in academia can appreciate this. We're told, oh, you just work, during the school year, you have your summers off, it's all great. Farmers are often told, oh, so you plant a little in the spring, you harvest, then you get your winters all off, and it's pretty relaxed. And that's not true. There's constant responsibilities to animals, to crop preparation, farm equipment, the whole works. It's year round. Location is also something that I think us in academia can now relate to. Farmers tend to live and work in the same place. And we have been doing that over the last year, and it brings its own set of stressors with it. You don't ever get away from what you're doing. Often farm families are multi-generational, and sometimes within the same farm site, you can find grandparents, parents, siblings, children, and that brings its own type of familial conflict that can be there. There's a lot of stigma associated, especially with rural farmers. It's that don't show the weakness, we can do this, we're always strong type of persona that's there. In the Red River Valley, we're very stoic. And this leads to stigma, not wanting to talk about concerns that that we're experiencing. And we don't have a lot of access to relevant care. So you looked at those two maps that show that rural areas are often lacking in healthcare provider and mental health professional shortage. We're in shortage areas. In addition to these typical kinds of things, farmers often face extraordinary stressors like the weather. We just can't control it. Is it going to be too dry? Is it going to be too wet? Is there going to be a tornado? Is it going to be too cold? And I did include a little picture for you in the bottom. This is just from last year. This combine got buried. The field was incredibly wet. And my brothers looked at least $38,000 of a repair cost for just this one combine alone. A few short months later, one of their sugar beet trucks was quite damaged, and that added another $65,000 in repair work. So those are the things that you can't always predict. You can plan for them, but as any of us know, things usually cost more than what we had anticipated. They have no control over the market prices, tariffs that are being sued. Debt and cash flow is constant. Is there enough money to cover? How do we manage the debt? Will there be funding for the next year's farming activities? And then healthcare costs. And we find in farm families, especially, that often one parent or one spouse often holds a second job simply to cover things like insurance, so that they have that accessibility to insurance rather than having it come through the farm itself. Okay. Next slide. When we talk about the family impact, and here, I did want to highlight a little bit more focus on women. Predominantly, we have farm producers in the United States who are males, although that is really increasing. We're seeing more and more female farm producers be developed and take over farms. But when we look at their role on the farm and the stress that they're experiencing, we have seen in the literature that women are far more likely to experience stress. And we know that farm women often play a very supportive role, helping husbands, spouses deal with their stress and frustration, but often don't get that same support in return. Currently, we feel that about 78% of women are involved in those day-to-day decision-making rules on the farm, and they're not getting that reciprocal support coming back to them. So we're seeing elevation in farm stress experienced by women, especially. Children are not immune to the stressors that are there. They often have to work on the farm. They identify very closely with the rural values, their family values, and their stress can be exhibited physically, emotionally, socially, just as with adults. We might see them acting out more. They might complain of headaches. They might be socially disengaged from their peers because of the work that they need to do on the farm or contribute, or maybe they don't have a ride into town to go participate in different activities. So that all will come through in their behavior. Okay. COVID is worth mentioning. So, we've all experienced COVID stress. And if we look at specifically on farm stress, many farmers have reported it's just one more thing that I can't control. It just gets added to that list. Some farmers have experienced disruption in their supply chain, additional financial stress, limited access to supplies, inability to pay their employees, just like small businesses would, and then finding increased workload of more that they have to do if they can't pay to have extra people helping them. It's also connected to an increased use of substances. We're seeing this across the nation with everybody, that if they're especially out of work or having additional financial stress, they're at home more often, they're engaging in a little bit more substance use. Isolation, completely playing into the stress that we're all experiencing directly from COVID, and then that impact on their coping mechanisms and not having those social types of activities to engage in, to find that support in, to help get rid of some of that stress. Okay. So how does stress impact overall health? We know that stress accumulates over a lifespan. Some of the literature has noted that lifetime stress can actually exceed tobacco use, excessive alcohol use, and physical inactivity, leading in itself to more morbidity and mortality directly contributed to stress. If it's not addressed, it doesn't lead only to physical illness, but it also contributes to mental health concerns, substance use disorder. We've seen a higher increased rate of suicide, and vice versa. If we already have substance use disorders that are present, mental health concerns, and then we add the form stress, it just adds to that cycle that we're seeing. Many are attempting to self-medicate with alcohol and other drugs. And again, as we talked about, especially in rural communities, the stigma that's there, that stoicism that's there, it's often seen as a sign of weakness if we want to reach out for help and support during these times. Okay. This is one of the diagrams that is in the toolkit, and we did put a link for you. It's an interactive link, but it's a nice way, especially with students, to kind of look at that head to toe impact of stress across the whole body system, and being able to demonstrate the different things that we often didn't think about. And one of the things is we're doing the research to put this together. For example, a farmer might come into, say, a primary care center to have his blood pressure checked. We find out that there's high blood pressure there. If we do our work and we do those additional assessments, we might find that that stress is contributing to that high blood pressure. Diet is contributing to that high blood pressure, alcohol use. So sometimes we'll see that these kind of items that are listed on how stress affects the body might bring somebody in for that initial evaluation. But then as part of our assessment work, we find out the true impact that farm stress is having on this particular person. Okay. So then what are co-occurring disorders? And by definition, we're really just referring to a combination of a mental health disorder and a substance use disorder. There is a very strong bidirectional relationship between alcohol use disorder and depression, meaning that if we're seeing symptoms of alcohol use disorder, do we find that that's contributing to depression, or if depression was there first, is that contributing to the alcohol use disorder? And these are the two disorders that we chose to focus on in this particular toolkit, simply because they're a very common presentation for a co-occurring disorder. Co-occurring disorders are often developed secondary to biology. We've got a genetic impact that's there. We've got a past history of trauma. We cannot forget adverse childhood experiences that may lead into this, environment and life experiences too. Okay. If we take a quick snapshot at what mental health and substance use disorders look like in America today, this information is from the National Survey on Drug Use and Health. It's 2019 data that was published in September of 2020. And so you can see that we have collectively about 3.8% or over 9.5 million people older than age 18 who have both a substance use disorder and a mental health illness. So we've seen that there's been an increase in this since the year before. And if you look at that little blurb at the bottom, in 2019, 61.2 million Americans had mental illness and or substance use disorder, which was an increase of almost 6% over 2018 data. And this was contributed entirely to an increase in mental illness. So again, which one came first? We're not exactly sure, but we're seeing the co-occurring disorders being exhibited more readily. Okay. Here's just another peek at what this looks like. And it shows you where the arrows are, where we saw the increases. So noted increase in the 18 to 25-year-old age group, the 26 to 49-year-old age group stayed steady at 50 and older. But then when we put them all together, we did see this increase happen in that collective 18 and older age group. Okay. So if we look at the impact of co-occurring disorders on our rural communities, it's really interesting to note that most rural folks often think of substance use disorders as that inner city type of a problem. It's more of an urban type of a problem, but rural communities are actually impacted every single day. David did mention the RHI Hub, and they've got some great toolkits on that website as well that really address these rural specific types of concerns that we're having. In rural areas, we tend to have less availability to providers. That means less availability of screening, treatment options, and even recovery services. We do experience those workforce shortages, so that accessibility piece is impacted there. And sometimes accessibility means that we don't even have the transportation to get there. So if we live in a very rural community and we have to travel to a community health center or a local clinic, sometimes that transportation is what's really impacting that piece. And then if we look at acceptability, again, it's that stigma piece. Are we feeling open to be able to talk about the concerns that we're having? And are we feeling like we have a culturally safe environment to go to in a rural or local clinic setting? Okay. Only about 7.4% of people with diagnosed co-occurring disorders are actually receiving treatment for both disorders. We do know that you can't treat one and expect the other one to resolve. They do have to be treated together. If we can have access to flexible community-based wraparound or integrated services, that might increase that ability to fully treat the condition. But we also know that there's a lack of capacity in healthcare providers to identify and screen for substance use disorders and mental health disorders. And this is where we were really hoping that we could make a difference by introducing some of these concepts earlier to our students as we're getting ready to help prepare them for our future workforce. Okay. All right, and so I think we turn it over to Abby now to help take a little bit deeper look right at the toolkit itself.
Yes, so we will take a deeper look at farm stress and co-occurring disorders through the toolkit. So you can go to the next slide. So the case study is one of the biggest parts of the toolkit. We kind of took a case study, John. We focused on John, who is a 39-year-old multi-generational farmer in a rural community. He is married and he has 3 children. So we kind of take John from the start. We discuss the stressors he's facing that Meredith went over. And then we take him kind of through how he would experience healthcare in his rural community, how he would go to a primary care or the emergency room, and then how we weave in how he's diagnosed and how he receives treatment in his rural community. Some of the things that students can learn from John's story is background on rural communities and co-occurring disorders, understanding farm stress and the impact on John and his family, how it impacts not only him, but his family and also the community. If it is a majority farming community, farm stress can affect the whole thing. An introduction to SBIRT, which is screening, brief intervention, and referral to treatment, including barriers to care. Insight into compassion fatigue, often experienced by rural healthcare providers who provide care for families impacted by farm stress, but they themselves can also be impacted from farm stress. And now we were going to take you through the actual toolkit on the website. I also want to thank David. He is our tech wizard, and he is running all this tech behind the scenes for everybody, to make it easier for everybody to see. So on page 10 and 11, you will see the typical stressors that farming families can experience. So they have typical stressors and then the extraordinary stressors. Like Meredith talked about, those include constant responsibilities, location, the multiple generations that can be involved within a farming family, stigma, access to relevant care. And then the extraordinary stressors are going to be the weather, which is one of the biggest, market prices and tariffs, debt and cash flow, and healthcare costs. And then on page 17, you will see some of the information on alcohol use disorder and stress. You will also see the cost of excessive alcohol use, both per drink, which is $2.05, and per person, which is $807. It also discusses what binge drinking is, which is 4 or more drinks consumed on one occasion for women and 5 or more drinks consumed on one occasion for men. Then on page 20, we have the why. Why don't providers ask the questions about mental health and substance use disorder during a primary care visit? It's a difficult topic, and the stigma around it can interrupt why they don't want to ask. The lack of time, indifference, or lack of connection with screening. And then on the how, we introduce here the SBIRT, the screening, the brief intervention, and referral to treatment as a technique to use not only for substance use disorders, but for also mental health disorders. So then on page 21, we have information about the screening. So for John's specific case, he fills out the Audit C, which is a 3-question screening tool to diagnose or just draw attention to problematic alcohol use. And then on 34, it discusses the symptoms, signs and symptoms of depression, and also the diagnosing of depression using the same SBIRT technique. And then we have on page 35, discussion of suicidality, also including the safety, talking about suicide awareness and making sure that people are safe if they are having those suicidal thoughts. And then on page 54, it talks about the toll on rural providers and caregivers, escalating substance use disorder and mental health concerns, resulting in co-occurring disorders being diagnosed, takes its toll not only on the providers, but the community itself. If there's only one provider in the town and they are feeling burnt out, that's gonna impact everyone in the entire community. And those are just the highlights. This is a very long document of 60 some pages, and it is just chock full of all sorts of different information. And now Meredith is going to talk about how you can integrate this into a classroom setting.
Okay, so, if we just sit down and kind of think about how it can be best used in a classroom setting, I really want to note that this, across all of our disciplines, we have social work, nutrition, nursing, all of us have a place in this document. And we really tried hard to make sure that this was interprofessionally inclusive when we're looking at that. As we started using the document, we did actually hold one focus group with FNP students who were ready to graduate or had recently graduated and had an interest in rural health. Students felt it was a great way for them to be introduced to farm stress, and it helped introduce them to the tools for screening for alcohol use disorder as well as screening for depression in primary care. One suggestion would be to hold discussion groups. So with this document being available electronically, it's very easy for an instructor to assign, and even if they have physical copies, but to assign certain page numbers for reading or have students read the whole document collectively and then sit back and have a discussion group about certain points. The end of the document really does focus on that compassion fatigue. And I think that it's never too early to talk with our students about that concept and the fact that it can happen very quickly if we're not taking care of ourselves. One thing that we didn't disclose to you is that at the end of the document, the ending is quite surprising. In fact, we have put in options for 5 different ways that John's scenario could end at this document. That is a great place to have a discussion group by assigning students to different endings and talk about the reality and what the impact of that particular ending would look like. In the past with students that I've worked with, I have tried something called an evolving case study. And that's where you would assign just pieces of this case study and then have the students stop, and then they would have guided questions to think about before they move on to that next section. So one of them might happen once they read John's case and see what types of symptoms he's presenting to. If you were in the nursing field, for example, maybe it's then helping think about, oh, what would I want to know next? What's missing from this information? What more detail do I need? Am I thinking about assessment tools and what I might want to be able to ask here? There's a time in the document where John does not react favorably to a suggestion by his advanced practice nurse. How would that impact those that were working in the emergency room setting? He didn't show up for some counseling with one of the social workers that was there. What would that feel like? So taking it step by step, having people critically think through the content that's there and then anticipate what's to come next or what we might want to look at down the road. It's also a great toolkit for getting students to talk about their experiences with rural, especially if we have a mixed classroom where we have students from cities, urban settings, and rural settings. I think David mentioned that really early on that, those of us around here are maybe a little bit more familiar with what rural healthcare means. But when we have students who come from larger cities, they may not. And so allowing students to share their experiences or their identity with rural is actually very empowering and very enriching to a group conversation. So using that as a tool. Always using prompts for critical thinking. I think doing some of the research to put this document together, really learning more about that family impact, that pediatric focus and what kids are experiencing was pretty enlightening. Suicidality has its own, it's its own concept. It's something that has to be addressed within the document, but can be looked at separate as well. And the cultural impacts that play into that rural stoicism that we've talked about and what culture looks like. As well as the healthcare challenges. Do we have students who want to work in rural? Is this something that could pique their interest in working in rural and have that type of experience as a student? We talked about some of the closing scenarios and looking at what that next step might be. It's always important for students to look beyond what's right in front of them. So while the scenario might be what John experiences, what is that followed or that impact on his family, on that partner, on the community, if devastation occurs or if things start to go well. And then we just always offer ourselves up. So I always love to talk curriculum. If faculty are interested in working through the document or have questions, that's part of what we do. It's called technical assistance or TA requests through the TTCs. You basically would contact David or Abby, and then we can put together a session to sit down and work through the document. We also have a number of other toolkits very similar to how this is set up that might be of interest to you to include in your classrooms. We have one that will be coming out shortly on intimate partner violence. We've done a couple that have looked at school mental health, and they can be used in similar fashions or very different. So it's we're trying to really broaden those resources, or we can help connect you to resources that can make this be a very fulfilling part of a curriculum for you. Okay.
All
Do
right.
you want me to cover, Abby? Okay, so it looks like we had just a couple more slides that we need to go through. So Abby did mention SBIRT. This guide actually breaks down SBIRT. And this is something that is a technique that students can use to learn how to do these particular assessments. On the addiction technology transfer center side of things, we have given multiple trainings on SBIRT in itself. And so that's something that we could always offer up to your classes as well. And then finally, looking for ways to have that interprofessional collaboration. So I know many of our students at the undergrad level do participate in the interprofessional healthcare course. So this is, again, another great tool for talking about the role of different providers in rural healthcare and how we work together. Okay.
And I just wanted to get in here and focus a little bit more on self-care. I know Meredith touched on this, and it's something that I think is really important to highlight at the pre-professional level. I did direct care mental health work for several years, and I will say that addressing my own self-care and figuring out ways to deal with compassion fatigue as I experienced it was something I was never trained on when I was getting my undergraduate degree, and it would have been very helpful for me. So in addition to that, and as a really nice segue into something that the MHTTC is working on, we do have a self-care and provider well-being supplement that was just funded back in November. So one of the things that I would, I guess, encourage you to think about of how this could integrate into the classroom is just how you can start that discussion around self-care and addressing and responding to compassion fatigue early. Who are some good mentors that already exist in the classroom that understand what practice and what direct care work is really like, and can give some good tips to those students before they enter the workforce and as they enter the workforce. And we do have existing resources on this that you can access now. one of the things that we highlight in the toolkit is the professional quality of life scale, or it's also called the ProQuil or ProQL. People pronounce it a lot of different ways. But it's a tool for self-assessment of professional quality of life, and it measures compassion satisfaction as well as compassion fatigue. And their website has a lot of really great resources around understanding what compassion fatigue is, what compassion satisfaction is, and how those things can contribute and lead to burnout, and also cause or lead to secondary traumatic stress. So really would recommend that resource for anyone who's looking at it. And I'd be happy to share our website that has our provider well-being resources as part of our supplement. And then finally, I did want to just close out by reiterating, our bottom line takeaway from this is that farm stress is not just a farm problem. The best way to address this is to work collaboratively to respond to the needs of individuals in our community. And I know Sherry already mentioned this in the chat box, but if you would like a physical copy of the toolkit, it's really great. It's really big. You can definitely send an email to Sherry or drop something in the chat. I know she's keeping track of those things. We're happy to send you copies of this for free. And then one final request of all of you. Again, if you could take a brief moment to complete an evaluation about today's training, that really does help our program. It's literally the only thing SAMHSA asks of us. And with that, I think we'll move to questions. And I'll also share some links in our chat box.
Well, I'll have to jump in here. Great job. It's very fun to be part of a team of people doing this really important work. And I just want to say this product is incredibly informative and helpful, but it's also very elegant. As you saw the photos and the stories, they tell a story throughout the product. Our regional administrator from SAMHSA, that funds us, has asked for a box of this product, and he's been distributing it far and wide. So it really is innovative, it's creative, it's thoughtful. And I think, Meredith, your comment about how it might be integrated, and Tracy Evanson did the focus group with family practice nurses that were really looking at, FNPs, that were looking at this product and how they might use it. Do you want to say more about how you're seeing it integrated? Because we're part of the college and we want to serve you. So maybe a little more about how it could be integrated in the curriculum.
Sure. So, did give that list of different things to look at. I think it's really a toolkit that could be used as part of assessment. So there are very specific screening tools that are in there. Like we said, with the ATTC, which is an alcohol use screening tool. And then the toolkit itself also goes into detail with the PHQ-2 and the PHQ-9. So the patient healthcare screening tools to look at depression symptoms. So if we're looking from an assessment standpoint, not only is it a great way to start talking about the impact of stress, physical and emotional stress, it's a great way to introduce screening tools. So I see that fitting very nicely into assessment type of courses. On the more conceptual level, when we're looking into those social services, for example, and thinking about social work students who might be out in the community, we do really focus on a social worker who works in a community healthcare center, and all that social worker takes home and has to deal with from the compassion fatigue part of things, but the assessment that she ends up including, and I think it really highlights how she works not only with the client, but the client's family. There's a short entry in there where John's spouse really breaks down over what's happening. And to me, that really shows how social workers often encompass that whole family and wrap their arms around that. I think that the toolkit can be used at the undergrad level, master's, graduate level, doctorate level, just depending on what you want to pull out to be able to use that. When we look from the nursing standpoint, and we've got nurses that are working and overworking in these rural healthcare settings. And what I mean by that is that they have such huge responsibility in a hospital, not knowing who's coming in and who's going to be admitted, or maybe they're working in these clinic systems. We talk a lot about that dual role, that goldfish effect, what it feels like to be that provider who holds the responsibility for caring for their community members. And it's a great way to talk about that impact in discussion groups, or as we mentioned, giving rural students a chance to talk about their practicum experiences, talk about internships that they've had in rural areas and how they've had an opportunity to work together. So I think, depending on whatever discipline you're in or how you want to use the toolkit, there are niches within the toolkit that can be used at all of those different levels. And that's what we, meant by saying a TA request. If it's helpful to talk that out, we can do that. Let's talk about how this toolkit can be used in your particular curriculum. It's something that also means the whole college is talking about it. It's again, that collective input throughout the college that we share the work in these particular areas.
And I would add one thing. One of the most important things that you can do, and I see Elizabeth has her hand up, is really prepare people on these aspects of behavioral health, mental health, and addiction. The more all of the folks in the college, nutrition, dietetics, you guys have great background in motivational interviewing, which is featured as well, and social work and nursing. The more people can come up with an understanding of behavioral health, because they will all deal with these dynamics, the better. So it's great to have this product and present it. Thanks, you guys. Great job.
Elizabeth, did you have a question?
Yeah, so I teach in the advanced health assessment, and all of this content speaks to me growing up in North Dakota. It makes sense. What I'm wondering is, as our footprint of students broadens, and we have a lot of students who this seems very foreign to them. They can't relate to farming and being the only provider in a rural clinic. Is there a way that this material that you see could be integrated with group work, where you have students coming from different backgrounds and different clinical settings? Because I feel like that for me in the courses would be beneficial. This is going to be received differently individually if somebody's learning this from the metro Minneapolis versus some of our students in rural North Dakota, where this applies to their entire family. They get this right away. So I'm just wondering how you see that being able to be utilized.
I can jump in here a little bit. I do think it's absolutely lends itself to group work and looking at those mixed groups. So one, learning from each other and what those experiences are. But because the toolkit really talks about that screening and assessment and that impact of stress, we're just highlighting farm stress here. That doesn't mean that they aren't going to find urban clients who have this stress. So if anything, it's a way to talk about, somebody came in, John actually comes in with reflux and high blood pressure and maybe isn't sleeping so good. So that happens across the nation. So using it as a way to say, here's somebody who's demonstrated these symptoms and came in with this. What would this look like in Minneapolis? What is a typical primary care client? What do they look like when they come in with this particular complaint? Have you thought about the overall impact of stress? Maybe for them, it's the loss of a job that has brought them in. So I think it's the toolkit helps you to prompt those questions. And from an assessment standpoint, it's that what's next? In my head, as we were writing this document, it was like, okay, what's the differential diagnoses and what would be the next thing I'd want to know? So simply starting with a case study and replacing John with a 50-year-old professor who works at the University of Minnesota, what does that stress look like? So I think it's a way to have one case study as an example, but students could share multiple case studies or create a case study from somebody who's representative of the clients that they work with. If they work with a homeless population, what type of screening tools would we need there if they come in with this same common complaint? Maybe their stress is going to look a little bit different. It doesn't mean we still shouldn't include an alcohol screen or a substance use screen and a mental health screen. So I think it's trying to impress that co-occurring mental health, substance use disorders, whatever that combination, are skyrocketing in the nation right now, regardless of where you live. This is just one example of what a rule looks like. So I think the content is applicable across many populations.
Awesome. I'm excited to use it. Thank you.
This is Tracy Evanson, and I would just add, don't I think, don't ever let those Minneapolis students, in your example, don't ever let them think that it doesn't apply to them because it's rural. Because the thing I always try to impress upon students also is that even if you don't live in a rural area, even if you're working in an urban area, you're still seeing rural patients, because rural patients oftentimes will leave because of what David talked about with that fishbowl effect. They don't necessarily want to be seen by their providers in their rural communities. And so they do often leave and go to an urban community to get their health care.
Do we have any other questions, comments?
Yes, a quick comment. So I think to piggyback off what Tracy shared, and I kind of have this qualitative research hat on now, and I'm thinking the benefits are the benefits are transferable to other populations and to other communities or to other contexts. So there is that transferability element, which is very, very important. And so it may not always be generalizable, but yes, in terms of it being transferable, that is very, very important. Yeah, so thank you.
I would also add that we've conducted many needs assessment. Tracy's done one for ATTC. We've done several for MHTTC. Co-occurring disorders, along with trauma-informed care, and quite frankly, compassion fatigue, are always the top 3 needs that providers identify. So this co-occurring product was really responsive to the needs in Region 8, but the needs really throughout the country. And that includes probation and parole officers, includes behavioral health care providers, it includes healthcare providers. And I think David mentioned the well-being supplement. We're really working hard. I would mention that the research is incredibly alarming about the toll the pandemic's taking on our nursing workforce, and especially the millennials, some indication of burnout and concern. So I hope David can put that link in there and you can look at some of the work that we're doing in compassion fatigue and well-being, because it's really critical, I think, as we prepare nurses. And some of it's just the issues of gowning up and gowning down to take a break. And the research is becoming very abundant with concerns about particularly nursing workforce working bedside in critical care. So just doing a shout out about that as well.
Thanks, Thomasine. And I do have a screen share up. We do have a blog series that we've started highlighting voices from across Region 8 and how they are responding to their own self-care and their own compassion fatigue and compassion satisfaction during the COVID-19 pandemic. And this first blog post here is from a provider that works in rural South Dakota. So just trying to keep with that theme of rural. Encourage you all to check it out. They're very fun reads too, and they're very engaging. So
I just wanted to address one of the comments that was just put in the chat box too. And it looks like Kat had noticed how we talked about binge drinking and what that looks like. And that's actually one of the first things that we talk about and teach when we do expert training, because that culture really plays into what we consider to be normal. And so, having somebody say 5 to 6 drinks is binge drinking, most people, when we do that training, have that exact same response. Like, what? That's not what I thought. So, we, using assessment, we talk about standard drink size. We talk about what is being out, what's being used out there that people perceive as a standard drink that really isn't. And we go through that information. We talk about that culture of binge drinking. Let's be honest, in many rural small towns, the bar is the hub for that community. It's where people go for support. It's where they go to meet their peers. So to them, it's not a place to go and drink. It's a place to go engage, be socially connected, and get that support. But binge drinking often then falls into that. So how do we give that support up when it's actually a drinking concern or an alcohol use disorder concern? So thank you for pointing that out. And we do try to go into that in the document too.
We're just about out of time. If anybody has any more comments or questions. This was a great session, lots of information. And I know we keep pushing you to the websites, but please check those out. We'll be happy to schedule additional brown bags on topics of request. All right, well, thank you everybody for joining us, and thank you to Meredith and David and Abby.